All right, good morning, everybody. Welcome to this week's AMSSM Sports Ultrasound case series. Thanks for getting up early on a Friday to join us. Just a quick reminder, so we are continuing with our fellow portion of this series. So we've got various sports medicine fellows throughout the country that are have an interest in ultrasound, have a skill in ultrasound, and are giving us some talks on some of these ultrasound-based cases. Excuse me. So today we've got Dr. Joey Pietropaoli. He's a East Coast guy, originally from Baltimore. He's currently the sports medicine fellow at Geisinger out in Danville, Pennsylvania. He has a emergency medicine background. He did his emergency medicine residency out in Johnstown, PA. He obviously has a strong interest in sports ultrasound, and interestingly, through this whole COVID thing, it sounds like has been developing additional interest in sports cardiology here. So anyways, without further ado, I'll pass this over to Joey and go ahead and get rolling.
So today I'm going to be discussing the ultrasound evaluation of really the elbow, kind of inspired by I guess I gave away the answer here a little bit early, but inspired by a patient who came into clinic and with a distal biceps rupture. First and foremost, I don't have anything to disclose. And let's just jump right into the case. So we had a 39-year-old male patient who was left-hand dominant come into clinic. He presented with left elbow pain that started 2 months prior to when he came to see us. He was actually moving a mattress at the time, and with an extended left arm, he felt his elbow hyperextend and heard a audible pop, and then he had immediate pain. He had a picture similar to this on his cell phone that he showed me in clinic. He said the bruising was was relatively instantaneous and over the antecubital fossa, and it actually lingered for the entire 2 months before he saw me. He did feel some weakness, particularly when he was kind of rotating the hand with supination and when he was flexing the left arm at the elbow. He localized a lot of his pain right to kind of the medial anterior elbow and the antecubital fossa. And he did move over and kind of point to some lateral elbow pain as well. He didn't have any numbness or tingling kind of radiating down or distal to the elbow, and no pain kind of proximally up in his shoulder. On physical exam, he had full range of motion with passive range of motion. He did still have this ecchymosis over the it was more medial to me, like right in the middle of the anterior elbow. And then he was tender right over the distal biceps muscle belly. And he was really kind of right over the anterior lateral elbow as well. Strength-wise, with flexion and extension of the wrist, he really didn't have any weakness or reproducible pain. His main reproducible pain was with supination of the left hand, and in comparison to the right side, he was weak there as well. He did not have any laxity of the joint with valgus or varus stressing. So we did get some x-rays, and as you can see, there's not much to speak of there. The joint space is well maintained, alignment is well maintained. We don't see any real evidence of even mild osteoarthritis or some degenerative changes there. And obviously, there's no fractures or dislocations. So the big question now is what to do next. A lot of times people may think of moving on to MRI, but this is, after all, an ultrasound case series. And so we decided to grab the sonocyte and take a look with the ultrasound right in clinic. So we chose, and for the elbow, we typically go with our high resolution linear probe, and that gives us the most definition that we want to get. And for most patients, this should be adequate. I don't see many cases where you may need to move on to a curvy linear probe in this case. So this kind of brings us to the overview of what we're looking for. And so the complete ultrasound examination of the elbow is broken down into 4 parts or compartments, and then each compartment focuses on specific structures as listed here. I think based on clinical evaluation, our biggest concern with this patient was the distal bicep. And so we kind of focused on the anterior and lateral areas of the elbow within this examination. But of course, each compartment in general, when we're evaluating the elbow, will correspond to some different pathologic conditions that will kind of that can be evaluated for and that you can rule out as you're examining the elbow under ultrasound. So again, we're going to focus right now on the first part of the anterior elbow, and this is kind of where we, based on our clinical evaluation, we wanted to start our exam and focus our main efforts. So we did talk about probe choice. Now we want to talk about patient positioning. As you can see here, I think when I was training in the emergency department, it's more so the patient kind of stays and you move around them. But as I, moving to clinic, as far as, being comfortable evaluating a patient, I think patient positioning becomes even more important. And so for this examination and to really optimize the images, I like to have the patient supine with the arm abducted and the elbow fully extended with some supination, as you can see here clearly, allowing us to really get a stable patient and allow for a high image quality. Just a little overview of the anatomy of the area. Main focus is going to kind of see in this image where my mouse is, where the distal bicep is actually cut off, and we have several structures that kind of come together in this area. And when we move, when we think about where we're going to have our probe, we place it in this transverse or short axis view first, and we'll end up kind of panning up and down this area until we find what I like to refer to as our home base. And a lot of the structures in there, I'll talk about in the next slide, but we're really looking at distal bicep. We can see radial nerve from that area, brachioradialis. Lying deepest as far as muscle is concerned is the brachialis. And then we can see pronator teres and median nerve as well. So as I mentioned before, I refer to the home base. I did play baseball, so it's kind of par for my vocabulary. Again, patient and probe positioning. And this will give us this image right here. And this is where I like to start all my examinations. I think that it offers a really good spot to just kind of, if you feel lost and you don't know where you really are, you can kind of always come back to this spot, find your area and reorient yourself, and then move on with your examination, move on to the next structure you want to evaluate. So right here, we can see we have our cartilage surface marked by the star, and it really gives a nice characteristic appearance. And so that's why I think it's a really good starting point and a really good home base to kind of return back to if you get lost. The brachialis is going to be lying kind of deep to everything. You can see it separated out. This would be more lateral, and the dot would be lateral in this case. And so we have the brachioradialis. We have the pronator teres more medially. The first arrow that pops up is going to be the radial nerve lying, and that's the hyperechoic structure kind of in this fascial plane between the brachioradialis and the brachialis muscle. We have the median nerve more medially adjacent to the pronator teres. And then this structure that's adjacent to, just lateral to the brachial artery is going to be the distal biceps tendon, the biceps tendon. And I'll talk more about this upcoming, but this does get a little tricky to visualize the biceps tendon clearly as we approach this home base. But to finish it out, we have the artery, we have the vein. The second star kind of in the septum at times, moving right through here, when sometimes I saw in textbooks it was described, depending on where you are in along the arm, you can sometimes see the musculocutaneous nerve in here as well. And so lastly, we have the capitellum and we have the trochanter. This is just a nice slide I found when I was kind of going through what to kind of share during this presentation. I really like it just because it puts everything together into one place. We have a cross-sectional anatomy and really gross anatomy of the elbow and what we're going to look at with the ultrasound, as well as what we see on the ultrasound screen, and then all while like seeing how we want to position our probe. So I like to, a lot of protocols I've seen when you're evaluating the distal bicep, they suggest going right to the long axis of the distal bicep where it inserts on the radial tuberosity. However, I've found that I like to evaluate it. We've found more so that if we kind of start proximal and glide distally with the probe in short axis, we like to evaluate the biceps tendon first in short axis as we follow down the bicep muscle belly. And so this is kind of the first clip that I have, and it's starting proximal, gliding the probe distally, and really finding and following down the biceps muscle to where the musculotendinous junction and tendon then form. I'll just play this for us. If we look right at the top of the screen where the cursor is, we can see where the biceps tendon begins to form. Biceps comes down and we begin to form the musculotendinous junction, and then it further kind of coalesces into the biceps tendon. Now, the problem is, and we can see here that as we get closer to the home base, as it goes through one more time, the biceps tendon really becomes subject to anisotropy as it dives deep. And that's, the main concern with trying to evaluate it for its full breadth in short axis. But that's the main focus of kind of this clip and looking at it in short axis. We can also see the brachialis muscle come in, as well as the brachioradialis pronator teres and the rest of home base as we glide more distally. So now this brings us to our patient. So that was what I just showed, was more of a normal anterior elbow. And so what I'd like to share now is a couple clips of the patient's examination while in short axis. And so I'll kind of, if you kind of focus on that same area of the screen as the clip progresses, we can clearly see that there is, it does not look the same, just to be kind of blunt with it. And we can see that the tendon itself, as we're expecting it to form this tight fibular structure and, really look like a tendon we're used to seeing, it really is bulgy, it's edematous, and it's significantly larger than what we'd expect. Also, we can kind of see it forming a lot more proximal than when we would anticipate seeing it. This next slide is just kind of further down. We couldn't really get we were moving slowly, couldn't get the whole thing. So we went ahead and took a second video here. And as you can see, it remains quite edematous, and looks like there's fluid interspersed within it. It's hypoechoic as we get closer to that home base. And really that hypoechoic signal is a lot, we're seeing that a lot sooner than we would anticipate if the tendon were intact, when we would think we were going to see anisotropy. But that hypoechoic signal is a lot more proximal than what we would anticipate. The next step is to evaluate the distal bicep in what we're kind of classically going to want to look at it in this long axis, closer down to the radial tuberosity and its insertion point. Here we have the patient, again, with the arm abducted. They're supinated, but they have about 20 degrees of flexion in this case when we're examining the distal bicep. I added this gross anatomy and anatomy slide just together to kind of give an idea of where the angle that we're looking at in relation to the radius and the remainder of the elbow. And what we like to do is when we're looking for the distal bicep, what we want to do is we want to start medially with the probe kind of parallel to what we would expect the radius to be. we want to glide back and forth. We want to start gliding towards the radius, and we want to angle our probe just slightly. And what we'll see in the next image is that we look for the brachial artery, and that gives us a very good acoustic window to evaluate the biceps tendon just inferior to that, just deep to that. And so again, here's patient positioning for the distal bicep long axis examination. And here we have kind of, this is our goal picture, so to speak, of what we really want to find. And we can see clearly a tight fibrillar pattern of the biceps tendon coming down and inserting on the radial tuberosity, and the acoustic window of the brachial artery just superficial to that. It's really, you can really appreciate the artery in video, given that it's pulsating at the time of the examination. So here's just another one of those kind of all-in-one slides showing the gross dissection, probe positioning, and what we would expect to see on our ultrasound screen. One of the benefits I think we all can agree on with ultrasound is that the dynamic examination is very helpful when we're looking at a specific area or a structure. And as we can see here, supination will really show motion of the biceps tendon. It'll show it tightening and getting taut with movement of the forearm. And this can A, help us identify what we're looking for, but B, help us identify maybe some occult partial tears or things like that. And it also kind of can clear up some anisotropy if we're looking at that at the insertion site. But here we can also see the brachial artery kind of passing back and forth as it pulsates and providing us with a good acoustic window. So that we just saw was unfortunately not the patient, but a normal example of a distal bicep. And here we have a clip of our patient's distal bicep, and I'll let this run a couple times. So here we can see the radial tuberosity coming into frame where we would expect there to be a clear insertion of the distal biceps tendon. However, what's lacking is that tight fibrillar pattern. We can see it maybe very faintly, and there could be some maybe scant fibers that are still there, but for the most part, it's a void where the tendon should be. And we can see kind of more laterally towards our dot over here that, or I guess more proximally towards our dot, we have a hyperechoic kind of bundle, and it looks as though that is where the distal biceps tendon has kind of settled after this essentially complete rupture, and that's where we have our proximal stump. We did want to go ahead and give a measurement to estimate how much retraction there would be, and in this case there was 5 centimeters. We did, as you can see, our most distal point here is right down to the radial tuberosity, and we did kind of go back into this proximal stump there. So we did not do it for this patient specifically, but I wanted to include these into the talk today. There are some other windows that we can evaluate the distal biceps tendon, and they aren't the best for seeing the details of the insertion point, but they are both dynamic examinations and evaluations that can really, if you're having trouble discerning a complete versus incomplete or partial tear, they can give some additional information. So the first one is going to be a long axis view of the distal bicep through our lateral window with the patient's elbow at 90 degrees, and they're going to be supinating at the hand as we evaluate the ultrasound. And here we can see what we're looking for, and as we can see right here in the screen, we have our distal bicep coming in here. And if we play this, as the patient supinates, we can see tension building on the biceps tendon, which would indicate that the tendon itself is in fact intact. I'll just play it one more time. The second window is called the Cobra, and you have the patient flex the elbow, fully pronate, and then flex the wrist as well. And again, you're looking at head on over it's almost like a posterior elbow view. And what you're looking for is the insertion of the distal biceps on the radial tuberosity as it lies adjacent to the ulna here. And we can, as the patient will supinate and pronate, we can see the insertion kind of come into window. And again, this is just an added evaluation, and it's, you know, in more of a dynamic state. This is just another one of the kind of all-in-one cross-sectional pictures of the probe positioning, what you find on your screen, and our cross-sectional anatomy here. So continuing to look at the anterior elbow and long axis, we do want to look at our joint recesses. And first will be the radiocapitellar joint and long axis. And so here we see our image. We're looking at the radial fossa here with our fat pad, and then we see the cartilage, the hyaline cartilage over top of the capitella. Again, another joint recess to look for is going to be the Humeroulnar joint, and this is going to be in long axis as well. And here we have the coronoid fossa with our anterior elbow fat pad, and then we have the hyaline cartilage of the trochlea here. So that kind of rounded out, you know, the majority of our anterior ultrasound examination. We saw our median nerve in the home base view, and as it came into view, when we glided more proximal to distal, and you can evaluate it in that. What I did not include was a long axis view of that, but what I'd like to move on to now is our lateral elbow examination, and that will include the common extensor tendon, the lateral collateral ligament, radial head and annular recess, and more so the radial nerve than anything. And so for a patient positioning, we want to have their elbow flexed at 90 degrees again, and we have the probe. We'll look at these common extensor tendons in, this will help us look at them in long axis, short axis first. So just to look over some anatomy, we have the extensor carpi radialis brevis, extensor digitorum communis, and the extensor carpi ulnaris inserting onto the lateral epicondyle. And we'll glide our probe kind of in this fashion where we're moving up and down the lateral epicondyle to evaluate the insertion point of these tendons. And here we can see just that. As we come in, we can see our common extensor tendons inserting up onto the lateral epicondyle. If we pause, when the radial head is in view, we can see our radial collateral ligament, and we can see our annular ligament sitting on top of the radial head here. And so what we want to pay attention to closely is this insertion point onto the lateral epicondyle of our common extensor tendons there. This is included in this examination with this patient, even though we had a very high suspicion of the distal bicep rupture, to make sure we weren't missing anything or missing any associated injuries. We move on to short axis examination of the same area, and I've found this most useful just to scrutinize for bony abnormalities and cortical change, but you can still see some of the insertion points of these tendons there. Now, and here we just have you can see the lateral epicondyle come into view here, and as they bundle up and insert onto the epicondyle right there. And so if we kind of start from the beginning, we're looking at, in this region here, we're looking at extensor carpi, radialis brevis, digitorum communis, and extensor carpi ulnaris. And as they come in, and all insert onto the lateral epicondyle. play through one more time. And we do want to include the imaging of the annular recess, which is adjacent to the radial head. And just to make sure that we don't have any sort of fusion or hypoechoic signal there. We can see that coming down in this region here. And then lastly, we wanted to evaluate the radial nerve. And it's like looking at the anterior elbow and finding our home base, but we move it a little bit laterally. And as we can see in the anatomy, we focus right over top of the radial nerve, right before it branches off into the superficial radial nerve and the posterior interosseous nerve. And we'll kind of be moving our probe in this fashion here as we glide up and down those structures. And so here it is in short axis. We can see it right in the middle. Our radial nerve is present, and it is right as it kind of branched off a little bit distal to where ideally I would want to be. But we can follow the posterior interosseous coming down into the septum between the two heads of the supinator and come it right in here. Let's play that through one more time. The main thing we're looking for is any, increase in diameter of the nerve, any swelling of the nerve there. Finally, you can also identify this in long axis. It was a bit of a challenge, but you can see the path of the radial nerve coming right down this way between the two heads of the supinator. And again, this is a good view to kind of look for uniformity of the nerves and evaluate for any sort of change in size or kind of edema in the nerve or anything like that. This patient, did not have any abnormalities kind of associated with the injury he sustained, and the remainder of the exam, was normal after evaluating for the distal bicep. So this now we've done our examination, we have to put that into words. And so at our institution and where I am, we like to use a templated report, and it's really more of a checklist to make sure you're hitting all of the kind of high points that you want to look for. And each report it starts out with, especially so for example, in the elbow, our report starts and all four compartments are present within our templated report, and you can kind of add or subtract as you may need to customize your report. But we want to make sure we at least address every important structure that is included in a complete examination. And in this examination, most notably, the most notable finding was the complete full thickness tear from the insertion of the distal biceps tendon on the radial tuberosity with, approximately 5 centimeters of retraction. We do kind of just say the rest of the things are normal, but we make sure that it's known that we did look and evaluate them. My preference is I do like this kind of report personally, mainly because it helps me kind of keep a protocol and a checklist in my mind as I'm doing an examination. So a little bonus information for this patient, they actually had, they referred to surgery and they had an MRI ordered for them, which, I don't mind when there's a follow-up MRI ordered, mainly because I can check my work. And it turns out that the MRI was very consistent with what we had kind of noted in our ultrasound examination. As you can see, they comment on a near full thickness, 2 full thickness biceps tendon tear with approximately 5 centimeters of retraction. I think that, you can see when we did look at the distal bicep under ultrasound, we did see some leftover fibers. Maybe there was a few floating in there. And so, I think it's hard to sometimes, especially 2 months out, maybe with some scar tissue there. It was hard to nail down whether, absolutely complete to near complete, but one or two fibers isn't going to make too much of a difference. But so at this point, I'll kind of leave it for questions. Thank you guys for having me today. I really appreciate the opportunity to talk.
All right, thanks, Joey. Those were some really nice images that you had there. For the sake of time, I'll just make a couple quick comments, and then if anybody has any questions or wants to make any comments, feel free to unmute yourself. For me, if somebody comes in with concern for a distal biceps rupture, for the sake of making sure I don't miss anything, and also, for trying to get a complete examination, I'll include the medial elbow for a couple reasons. I've a couple times, clinically been fooled to think somebody's got a biceps, injury, and or truly there's, a UCL injury or something else. So I'll start at the home base, like you described nicely at the anterior elbow. You can see all of your, your quote unquote home base structures there. I'll start with biceps tendon there, and then I'll completely switch over to the medial elbow and look at all the structures there. Additionally, so Dr. Smith, so Jay Smith and John Finoff described this, pronator window or medial window as a way to visualize the distal biceps, and I think if you're looking at distal biceps from an anterior approach, it's gonna course and dive posterior at a pretty acute angle, and so to get a good view of the biceps tendon and the distal biceps and long axis, you're really going to have to heel toe pretty firmly on the patient, which can be quite uncomfortable. And then, somebody who maybe be a bit bigger, it can be challenging to really get that image. And so, looking medially through the pronator or medial window, you essentially have the patient side lying, elbow flexed 90 degrees and hand fully supinated, starting with the transducer in line or in plane with the axis of the humerus and sliding anterior. You can pretty reliably find the biceps tendon as it runs in the same plane as the brachial artery. I've found that it's quite a bit less uncomfortable for patients, and it gives you a really nice acoustic window to shoot through. So that's typically how I will visualize the distal biceps. I think those are the main comments I wanted to make. Does anybody else have any comments or anything? Okay. All right. Well, thanks, Joey. Great job. Next talk will be in 2 weeks. Dr. Shelby Johnson from Mayo is going to give a case on the distal semitendinosus rupture, and that will be on April 2nd. So, all right. Thanks, everybody. Great job, Joey. Everybody have a good Friday and happy March Madness weekend.
Thank you, guys.